Friends, we all know the world is full of problems, large and small, and resources are limited. So the question is, how do we solve problems? I don't intend to give any prescription today, nor do I have any prescription. What I intend to do is to share a story. And let's say something might emerge out of that story. One question which all of us keep on asking is, where should I work? And I'll begin the story with the year 1986, when Rani, my wife, and I had just returned from the US. And where should we work? And I'm sure many of the young individuals here, engineers, students, must be facing this issue as to where should I start working. One thing I learned is that if you have this question, go where the problems are and not where the facilities are. If you go where the facilities are, there is already too much of crowd. And you become a problem, yourself become a problem there. So better go where there might not be any facilities, but the places which are full of problems, you are badly needed there. In hindsight, it seems to me that yes, we did something right at that time and decided to go to Gadchiroli. Now most of the people here in Nagpur know Gadchiroli, but those who are from outside, for them, Gadchiroli is somewhere here at the far eastern end of Maharashtra, 1,000 kilometers from Mumbai, about 200 kilometers south of Nagpur. Gadchiroli is the least developed, poorest district in Maharashtra. Nearly 60% of the land is still covered by dense forest, where otherwise everywhere deforestation is occurring. There are 1,600 villages in the district, small villages, 150 households. And there are huge distances which separate those villages from each other. The transport, roads and communication, everything is poor. This bridge construction started nearly 25 years ago. And as you can see, the central pillar sunk. And the bridge was never completed. This bridge typifies the story of development in Gadchiroli. Never complete, every pillar sinking, maybe because of inefficiency or because of corruption. Now, whenever the floods would come, this river would become full, and 40 villages on the other side of this river would be cut off. So, Gadchiroli was full of such villages, and healthcare was badly needed. This was how people really used, this was the main mode of transport, bullock cart. Even sick women, sick children had to be transported by this kind of transport. So in Gadchiroli, surrounded by various tribal villages, we established our own village. And we call our own headquarter campus village ShodhGram, a research village. And what do we search there? We search for the health problems of people in surrounding villages, and if possible, solutions to these problems. Our philosophy of search is begin with the people. Second, knowledge is a lever of change, very powerful lever which can change the world. And third, we have all heard, think globally, act locally, but this is a little different. This says think locally. If you bring science, if you bring ideas, if you bring thinking to local problems, global action automatically emerges. Your actions start having global impact. So think locally, action automatically becomes global. So as I said, begin with the people. When we went there, in the very first month, there were huge floods. So for 8 days, our house was surrounded by water. We couldn't go out, no electricity, no milk, no newspapers, nothing. Then we started moving around in villages, Tribals, you can't meet them during daytime, they are busy in their livelihood. So you have to sit with them around night fire. And it's only around night fire that they open up their hearts to you. So we started asking them what were their main health problems. And then we continued this process, and after 2-3 years, when we constructed a tribal-friendly hospital for tribals there, we started organize annual jatra for tribals and People's Health Assembly every year. So every year, representatives from nearly 40 tribal villages assembled, and for 2 days they discussed what they thought were their priority health problems. And not only they discussed, but then at the end of it, we asked them to vote. So we men literally voted as to what were their health priorities. One of those priorities, one year, women said, our children are dying. 9 months pregnancy, difficult delivery, going through difficult labor, and after risking our own lives, a child is born, but our children die like flies. So to assess this, we established our population laboratory in 86 villages, which means no flasks, no test tubes. People are our laboratory. Villages are our laboratory. We established a system of measurement. Count every birth, count every death. There are many engineers here. You know that Niels Bohr's famous statement, nothing exists until it is measured. Even child mortality does not get a face, child mortality does not get an existence until somebody measures it and put a count on it. When we measured for the first time there in 88, the infant mortality rate was 121. Now what does it mean? IMR, infant mortality rate, is a very globally accepted measure of level of development and health services. IMR 121 per 1,000 live births, which means out of 1,000 babies born, how many die within first year itself? It means in Gadchiroli, out of 1,000 babies born alive, 121 would die within 1 year itself. Just for comparison's sake, IMR of Kerala is 11 and IMR of Japan is 4. Gadchiroli had infant mortality rate of 121 and a large proportion of those infant deaths were actually newborn deaths. Babies were dying within first 1 month of life, which is called newborn death. Now just to put this in perspective, this is not a local issue alone. This is a global issue. The most recent estimates, current estimates are that globally there are about 8 million child deaths, 80 lakh, 8 million child deaths every year occurring in the world, out of which India contributes the largest number contributed by a single country. Prime Minister called it the national shame of India. Very true. 2 million children die every year in India and half of them are newborn babies. So these newborn babies seem to be very vulnerable and one can imagine, fragile, delicate. Now can this be stopped? This is a challenge which actually women had posed before us by saying that our children are dying, and this is its national and global dimension. Now, every year 27 million newborn babies are born in India, and nearly half of them are born at home by home delivery. Other half are born in institutions, health centers, hospital, but even those who are born in hospitals, usually mothers are discharged within 24 hours. So whether born in hospital or born at home, these babies end up spending most of their newborn period at home. So if babies are at home for the most of the time, and if they die at home, newborn care must go where the babies are, where the neonates are. And out of 27 million neonates born every year, 1 million newborns are dying every year. Now 1 million looks at statistics, but imagine 1 million newborn babies with their faces, with their fragile bodies, with their delicate bodies. And now, I'm sure none of you had had opportunity to see a newborn baby born in some rural home, so let's visit. This is a photograph from a village, Mudza, in Gadchiroli. You can see this is a photograph of home delivery room where baby was born maybe 4 or 5 days ago. This mother is still lying here on charpoi, exhausted, pale woman. This baby is being given massage and bath by this old woman who could be traditional birth attendant, dai, or she could be grandmother as well. Now look at this baby. Delicate, fragile. 30% of babies born in India, which means really 9 million babies, are low birth weight, which means they are malnourished in uterus itself. They are malnourished even before birth. Such babies are very prone to become cold, hypothermic, and die. Some of these babies, nearly 10% of these babies, which would mean about 27 lakh babies, don't breathe at birth. They are asphyxiated at birth itself. If I ask you to pinch your nose, keep your mouth shut, and try to remain without a breath for a while, and then count seconds, you won't be able to really tolerate that for more than 30 seconds. Human being needs air, needs oxygen. The babies have to take first breath within those 30 or 60 seconds. If they don't, either they will be dead or they will be brain dead. They will be brain damaged. So this asphyxia is the second most important cause of newborn deaths. And this baby's bare arm maybe 3 inches away from, and dusted soles of this woman, this baby's bare scalp is maybe 4 inches away. So it is no surprise that these babies which grow up in this kind of environment, they get infected with bacteria. And when they get infection, it is called sepsis. It's life-threatening. Studies in pre-antibiotic era done in the US, in Yale University, tell us that if a newborn baby develops sepsis, and in those days there was no antibiotic, these studies were done in 30s and 40s, 90% of them died. So this is extremely life-threatening, more life-threatening than cancer. So these young babies, newborn babies, die because of either sepsis or asphyxia, or because they are born low birth weight preterm. Even when they become sick, where can they go? World Health Organization, the Indian Pediatric Association, and all global experts had only one solution: go to a hospital. And WHO stopped at that. If the newborn baby is sick, it's very serious condition, it's emergency, immediately baby should be hospitalized. But the real question is, where is the hospital? Gadchiroli district is 300 kilometers long. There is only one hospital in the entire district where a newborn baby can be cared for. Same is the story in most of the 400 various backward districts in India. And these babies cannot walk. And the mother who has recently delivered, there is a quarantine period. In the rural communities, that mother cannot leave that room and come out. Nobody should see her. Nobody should see that baby. She will catch evil eye. So a baby which is very seriously sick, but the mother cannot leave that room, baby cannot be taken out, and there is no transport, and the nearest hospital is 200 kilometers away. You can imagine what would happen to those babies. They had only one destiny. They were born in those delivery rooms. They either survive or they die in the same rooms. If this is the reality, if this was the tragedy, we said, this cannot be accepted. Something needs to be done. And with that, we decided to follow that we can't wait babies to come to our hospital. The hospitals need to go where the babies are. When China planned its health services in 1951, in the first People's Health Congress in China, they set to work very interesting principle. They said this was their guideline. How far a mother on foot can walk with a sick baby in her arms. Healthcare must be available within that distance. They didn't express it in terms of kilometers or miles or population ratios. How much that mother can walk. And as you can imagine, newborn babies just can't walk and this mother cannot leave that home. It really means newborn care must be made available where the babies are, which means it must be made available in their homes itself. With this idea, we conceived a new pattern of newborn care, home-based newborn care, with the goal to reduce newborn mortality by using the human potential in the village and give primary newborn care in the village. Now, though I said human potential, it really was a woman potential, using women in villages to provide newborn care. Now, this woman, her name is Kajubai. Kajubai is from a village called Ambeshivni in Gadchiroli district. Kajubai had 7 years of schooling. Her husband was alcoholic, but this woman had enormous desire to do something for her village. Energetic woman. So we selected one such Kajubai from each village. 39 such women were selected from 39 villages. We called them Arogya Doot, which means community health worker. And they became our barefoot neonatologists of their own villages. They were trained by way of a 36 days very rigorous systematic training program. They were trained to do various activities like giving health education to pregnant women, using a picture card and giving 36 various messages to pregnant women as to how she should take care of her own health during pregnancy and how she should take care of newborn babies later on. Health education is really a knowledge vaccine. So giving knowledge vaccine to mothers. And then these workers were trained to make home visits, go to every home where there is a newborn baby and almost like a doctor, do medical examination of the baby, record weight, record temperature, ask history, look for complications, record those everything. Here, a group of community health workers, they are learning if the baby is born at home and baby doesn't take breath, how to resuscitate such baby. Within 60 seconds, baby must receive oxygen and air, otherwise it is dead. And so, here they are learning on a dummy doll and they are using a medical device called Ambu bag. Very simple equipment. But using this, anesthetists often give emergency air to patients when they don't breathe themselves. So, they were trained to use Ambu bag and the same algorithm or very similar algorithm which American Pediatric Association, their training follows. 17 steps algorithm, but they were trained to follow those 70 steps within 60 seconds. So they went through a repeated dry drills so that when a baby is born and if baby doesn't breathe, within those 60 seconds she should be able to complete 17 steps without any mistake. It's a question of life and death. And look at those other women. One Arogya Doot is trying this and everybody else very curiously, very intent to learn. Rural women also have enormous desire to learn new things. Nothing reaches them. No new knowledge. Once they are out of school, they are only collecting cow dung and cooking. Any new bit of new knowledge, they are so eager to just receive it. If babies are born preterm, if babies are low birth weight, during winter, they become cold and they become hypothermic, I told you. What do you do when you go to Mount Everest? Or when you go to very cold areas, you use this kind of warm. So we created warm bags for newborn babies. And those babies could be kept even in winter in those warm bags. These were twin babies who were low birth weight. One was 1200 gram, another was 1400 gram. And these babies were kept warm at home. There is no incubator. There is no electricity. What else can you do? And then nearly 8 to 10% of these newborn babies develop infection, sepsis, and as we saw, which has a very high mortality rate. Now we have antibiotics. The problem is, who will give antibiotic to those neonates? Neonatologists, pediatricians, doctors are not going to go to each village and each home where the newborn baby is, where it can become sick in any time. So we finally decided that we will train Kajubais and workers like Kajubai to use a very strict scientific guideline, diagnose newborn sepsis, and give family the option, go to hospital. But if families say we just can't go, the baby is going to die, let the baby die, then as a last resort, community health worker can give antibiotics. So here, Kajubai is giving antibiotic injection to a newborn baby. This is the 4th day of sepsis of this baby. Now, question very naturally can be asked. And even if you are not asking, you might be asking in your heart, and many doctors have asked us this question, is it safe? Is it legal? Is it ethical to give antibiotics and these equipments in the hands of these kind of semi-literate women? So after training them for 36 days and their field practice, we invited a group of very senior pediatricians from all over India, 10 senior-most pediatricians of India. And the chairman of the Department of Pediatrics at All India Institute of Medical Sciences, Dr. Meherban Singh, whose textbook of newborn care, neonatology, every medical student in India uses, he was the chief of that committee. And we asked them to evaluate these community health workers. After evaluating them for 3 days, as the chairman of the 39 community health worker, go ahead. And that's how care provision started. We were very closely supervising, monitoring, all data were computer entered every day. So if there were some mistakes happening, we could immediately correct. With that, this model was very rigorously tested through a public health experiment, which in public health jargon is called field trial. So in 39 villages, where our intervention villages, where this model was introduced with the village consent, other 47 villages were government villages, program villages, where we did nothing, only whatever births occur, or if child deaths occur later on we came to know, we recorded. So we kept meticulous record only of births and deaths in government villages. Government program continued there as usual. In 39 villages, this intervention was introduced. And now, look at the effect. This is newborn mortality rate, NMR. Out of 1,000 live-born babies, how many die within first 1 month of life? That's called NMR. Now, when we started this experiment, this was the baseline year, 93 to 95. The NMR was around 60. The yellow line is the government area. We call it control area. And you can see from 93 to 2003, except for this 1 year, which is random fluctuation, but otherwise throughout this NMR has remained at 60 or above 60, which literally means that nothing happened in this country for nearly 10 years to reduce newborn mortality, in spite of 1 million newborn deaths every year occurring in the country. Because these government villages, 47 villages, represented what was happening in the country as a whole. And look at this blue line. This is the intervention area where home-based newborn care was introduced. At the baseline, it was 62. And with the introduction of NMR, home-based newborn care, the NMR steeply declined. And within 3 years, it came down to 26. And then with some random fluctuations, stabilized at about 26, 25. 70% reduction in NMR as compared to the control area. Now, if any new medical technology, if any new treatment reduces NMR by 5%, it usually in developed countries, it becomes a national headline. Because reducing NMR is supposed to be a very difficult challenge. Here, these women have reduced it by 70%. And then, look at the effect on the infant mortality rate. We talked earlier about infant mortality, if you remember. Child deaths up to the age of 1 year. The IMR, when we began our work in 1988 and measured it for the first time, was 121. And with these, community health workers provide treatment for pneumonia and then home-based newborn care. Look at the IMR. These ups and downs are called random fluctuation. These natural ups and downs occur everywhere in the population. So ignore them. Look at the trend. So from 121, this IMR reduced and finally settled at the level of 30. Gadchiroli still continues to remain the most backward area in Maharashtra. Gadchiroli is still poor. Gadchiroli is still semi-literate. It is still affected by various other problems, including Naxalite activities. Gadchiroli hasn't really changed much. What has brought this miracle? And interestingly, this IMR reducing to level of 30 in 2003 here, and that is the national goal which Government of India has selected for the entire country. To be achieved by the year 2010, and the IMR still in India is 50. While rest of the country is still struggling to achieve it, well, the deadline is already passed, Gadchiroli, these 39 villages have already achieved it nearly 8 years ago. Now, who did this miracle? These are the 4 types of women who did this miracle. This is the mother and grandmother who provided care at home to those twin babies. This is the dai, and this is the community health worker. This is from another village now. In last 15 years, such 2,000 very serious babies have been saved by these community health workers who otherwise would have been dead. Now look at these women, look at their faces, look at their clothes. Do you find anything very unique or different about them? Do these kind of women exist only in Gadchiroli? Or they exist in any village in India? Any village in Bangladesh, Nepal, Pakistan, Afghanistan, Africa, Bolivia, all over the world. In any developing countries, you will find such women, billions of such women, waiting to be given opportunity to save their own children. So it is these women who can do this miracle if we just allow them to do. That's why the logo of this model, home-based newborn and child care, is this. That home delivery room is dark. And that woman, mother, community health worker, she's helpless there. She had nothing. How to save my own baby? And open that one window of knowledge, window of opportunity, and that woman becomes empowered. And on her empowered hands, she can save the baby at her bosom. And what does it take? Look, she is same Kajubai now, 15 years later. Her hair has grayed. These are the equipments that she requires. This is that ambu bag. This is the weighing scale by which baby can be weighed. This is wristwatch, antibiotic, syringes. And this is a record on which she keeps very rigorous record of newborn's health, soap to do hand washing. All these equipments can be put in a shoulder bag, which she can literally carry. These equipments together weigh 1 kilogram. So with those equipments on her shoulder, and knowledge in her head, and the skills in her hands, and the compassion in her heart, she can convert any home or hut into newborn care ICU. And I am not exaggerating. I am not exaggerating. We have published in international journals that the mortality rates reduced by this community health worker in village care, the mortality rates are very similar to those observed in middle-level hospitals in India. So they are no inferior to hospital care. This is the potential of this approach. One thing, if you want any such new model to be accepted, to become credible, turn that into science. Without science, it will remain only an anecdote or only remain a personal success story. So we published this in the Lancet, not only published in 1999, but 5 years later, Lancet published a special volume called the Vintage Papers from the Lancet, which Lancet thought were the most landmark medical research papers published in the last 180 years. And it selected this paper from Gadchiroli as one of the milestone papers. So it has become now part of the science of newborn care world over. But the question still, next question was, people said, okay, Dr. Bang, you are great. This is your miracle. That doesn't help. If it is Abhay Bang's miracle, Abhay Bang would become a Baba. But that's not our intention. We want to save those 1 million newborn babies dying in India or 4 million world over. We want a method. We don't want a miracle. So if it is a method, then it should be replicable. That is the next test of science, scientific method. So we started another project called Angkor Project, selected 7 different sites in different parts of Maharashtra, tribal areas, urban slums in Nagpur, rural area in Nashik, Usmanabad, Sangli, and with local NGOs, same method of selection of community health worker, training, providing care, and rigorously, meticulously observing the impact, measuring the impact. Within 3 years, in every place of those 7 experimental sites, it was feasible to introduce this model, it was successfully accepted, and it reduced infant mortality rate and newborn mortality rate at each of those sites. So Angkor Project proved that this is not only one place miracle, but this is a method which can be introduced everywhere. With this powerful evidence, Planning Commission studied this model in great details, and finally, this was selected to become the mainstay of India's strategy to reduce child mortality in the 11th 5-year plan. And now, very recently, Health Ministry, Government of India has come out with national guidelines to introduce home-based newborn care Gadchiroli model in all villages in India, all over the country. Then Health Ministry has already introduced a community health worker. 800,000 community health workers have been introduced in India. They are called ASHA. And these ASHAs are being given now training in home-based newborn care. The training manual, program, everything is based on the Gadchiroli model. And trainers from various states are coming to Gadchiroli, and you will be surprised. Not only I and our team teaches them, but we send them, all those national trainers, we send them to live with community health worker in village for 4 days and learn from Kaju Bai and Maya Bai and Tara Bai and Kanta Bai, learn from them how to provide home-based newborn care. Kaju Bais have become trainers of the national trainers. So, this has been introduced in not only different parts of Maharashtra, Indian Council of Medical Research has introduced in different parts of India, and now Government of India and various state governments have introduced in various districts. Soon it will become, whole of India will be covered with this. But look at here, even Bangladesh has started it. And the Bangladesh trial is also published in the Lancet, and it has shown that it reduced child mortality in Bangladesh also, and in Nepal, and in Pakistan, and 4 countries in Africa. African countries sent their national delegation to Gadchiroli and learned this method through training program, and then went and introduced that in Africa as well. The Prime Minister of Ethiopia sent a national delegation to Gadchiroli. They observed and studied this model in Gadchiroli, went back, reported to the Prime Minister, and similar kind of model has been now introduced in Ethiopia also. And here you see the program managers and trainers from Ethiopia and different African countries are learning this method in ShodhGram. Finally, the global organization, international organizations, World Health Organization, Unicef, which most often decide the global policy guidelines, and USAID and Save the Children in 2009 brought out policy guidelines endorsing the home visiting and home-based newborn care model for all developing countries wherever newborn care is not available. So something which started locally, started with what appeared to be a local problem, but the problems are often universal, global. So from local to global, this is how it spread. So friends, the world is full of problems which need solutions. Newborn deaths was one such example. But it is the power of the knowledge and the power of the people which can generate such kinds of solution which can be applied everywhere, which can be applied universally. And these are very self-sustaining methods because they don't depend on Abhay Bang. These methods use the local women. These methods use local people. So engineers and doctors and scientists and business managers like you and me, we might be able to act as a catalyst. But in the final analysis, it is the people who need to be empowered to be able to solve their own problems. So what do we learn? As I said, I'm not going to end with any prescription, but I'm going to end with an approach, with a method, which hopefully can be applied to any problem of the people. And this comes very surprisingly from Tao Te Ching, ancient Upanishad of China. The ancient sage Lao Tse very wisely, nearly 4,000 years ago he said, go to the people. And as if we literally followed step by step the commands of Lao Tse, he said, go to the people. We went, live amongst them. We lived, love them. We tried. Listen to them. Don't impose your ideas on them. First, listen to them. Learn from them. They are not empty boxes. Learn from them. Begin with what they know. Build upon what they have. And what they have is people. India may not have a lot of dollars, may not have a lot of capital, other kinds of capital, but we have huge, huge human capital, 1.2 billion. We might be soon the richest human capital country in the world. So don't look at that human capital as the burden, population burden. Now, fortunately, the discourse has changed and we have started talking about demographic dividend. That is people's power. Don't use that demographic dividend jargon. It is people's power. And by using people's power and by giving the lever of science and knowledge in their hand, any problem can be solved. And the Lao Tse in the end says, when this is done, what he is advising, if that approach is followed, he says, when the problem is solved, people say, we have done it. That's what we all want to happen, isn't it? Thank you.